Hi there. My name is Daniel Aloise. I'm a medical student from FIU HWCOM College of Medicine, currently doing my rotation at Broward in June 2022. So for my case presentation, we are going to be talking about ectopic pregnancy. So for our case, we had a 28-year-old G3P2 with her last menstrual period 8 weeks ago and 2 prior full-term C-sections without any significant past medical history, presenting to the ED with 12 hours of abdominal pain and vaginal bleeding. She was diagnosed with an ectopic pregnancy 3 weeks prior to this by her OBGYN and received IM methotrexate 1 week after this diagnosis. She presented to the ED 4 days ago and was discharged after labs revealed a downtrending beta HCG going down from 4,000 to 2,900 and a transvaginal ultrasound that revealed an extrauterine gestational sac measuring 3.1 centimeters without cardiac activity in the right fallopian tube. Today's transvaginal ultrasound showed a mass measuring 3.5 centimeters in size. The patient is afebrile, normotensive, tachycardic, and tachypnic. She's found in severe acute distress with nausea and rates her pain 10 out of 10 and constant, localized primarily to the right lower quadrant with diffuse abdominal tenderness and guarding on physical exam. Which of the following is the most appropriate next step in management of this patient? A, methotrexate IM injection, B, Pitocin, C, suction curettage, D, urgent surgical consultation, or E, indomethacin. So the answer is D, urgent surgical consultation. So going back up here, we do have an image that shows the fallopian tube of not our patient, but another similar patient, which is the most common site of ectopic pregnancies. As you can see here, the gestational sac should be located within the uterus, but it is, in this case, located in the fallopian tube, as was the case in our patient. Ectopic pregnancy, which is defined as a pregnancy in which the blastocyst implants in a site other than the endometrium of the uterine cavity, is the leading cause of pregnancy-related maternal mortality in the first trimester. It accounts for 4% of all pregnancy-related deaths. The fallopian tube, as mentioned before, is the most common site, accounting for 96% of all ectopic pregnancies. Other locations can even be in the cervix and other locations nearby. So, an ectopic pregnancy, used to describe a gestational sac implanted outside the endometrial lining of the uterus, confirmed via transvaginal ultrasound. IM methotrexate, going through our other answer choices, is a treatment of choice for patients who have a diagnosed ectopic pregnancy early on in pregnancy, as it has been shown to have efficacy similar to your surgical treatment options, your salpingostomy and your salpingectomy, without necessitating these invasive surgical options. Patients can receive methotrexate so long as the following characteristics are met. They must be hemodynamically stable, which our patient was not. She was tachycardic, she was tachypnic, she had an acute abdomen, she was guarding and in severe pain with vaginal bleeding. A beta HCG of less than 5,000 units, which our patient did have. No fetal cardiac activity. Again, our patient did have this. No, it did not have any fetal cardiac activity. And the ectopic mass size of less than 3.5 centimeters, which is right about where our patient's was. And they must be willing and able to comply with post-treatment follow-up. Very important, and something that our patient may not have been perfect about doing. She was coming back into the hospital and wasn't regularly seeing her OBGYN. Additionally, on transvaginal ultrasound, though they did see the mass of 3.5 centimeters, it actually did rupture. So when a patient presents with hemodynamic instability and clinical suspicion for a ruptured tube, the patient should be taken immediately to surgery for salpingectomy to prevent hypotension and shock, which may otherwise have lethal consequences for the affected patient. And again, going through the other answer choices, Pitocin is a natural form of oxytocin that causes the uterus to contract, used in the induction of labor. So it's used in the management of viable intrauterine pregnancies, not for an ectopic pregnancy. Indomethacin is a tocolytic that can be used to inhibit uterine contractions. So again, that's typically used for viable intrauterine pregnancies in which the mother has gone into labor before 32 weeks gestation. Suction curettage is the most commonly used form of abortion in the United States, can be done up to 14 weeks of gestation, and is the treatment of choice if you have a hydatidiform molar pregnancy. So ectopic pregnancies, as I've mentioned, result from the blastocyst improperly implanting in an area outside the endometrial lining of the uterus. This may be due to a damaged or misshapen fallopian tube, with risk factors including prior ectopic pregnancy, tubal scarring, which can be due to PID, endometriosis, abdominal surgeries that can create adhesions. Smoking is a risk factor, as well as increasing maternal age. So the overall incidence of ectopic pregnancy in the United States is estimated to be about 6.5 per 1,000 pregnancies, with the incidence increasing along with age. So for the ages of 15 to 19, it's only 2.8 per 1,000. 20 to 24, it increases to 4.4. 25 to 29, that increases to 7.4 per 1,000. 35 to 39 and 40 to 44, you're looking at almost 10 per 1,000. So you're looking at about a 1 in 100 chance there, nearly double the overall estimate and nearly 4 times the rate of that of the younger people that are going to be having pregnancies. So as far as treatment options, intramuscular methotrexate has been shown to have similar efficacy to the surgical treatment options for management of ectopic pregnancy. This can be done as a single IM injection, or it can be done with multiple IM doses. But it is imperative that patients receive education on the importance of adequate follow-up after receiving methotrexate, as it may not always result in complete resolution of the ectopic pregnancy, as was the case in our patient. So in scenarios where the aforementioned characteristics are not met for methotrexate therapy, if the size is bigger than 3.5 centimeters, beta HCG is greater than 5,000, there is cardiac activity, or if they are unable to follow up after receiving methotrexate, then you're going to want to do the surgical options. So methotrexate therapy has been shown to be unsuccessful. If it has been shown to be unsuccessful via transvaginal ultrasound or serial beta HCG measurements, then you're going to be looking at doing a salpingostomy. And then if you have a ruptured ectopic, then you're going to be wanting to do a salpingectomy, which was the case in our patient. So for some further discussion here, differential diagnosis: when a patient comes in that's pregnant with some vaginal bleeding, you're going to want to be thinking about spontaneous abortion, placental abruption, uterine rupture, placenta previa, vasa previa, as well as ectopic pregnancy. So some key points that you're going to want to be looking at is the age of gestation. So you want to get their last menstrual period, as well as any prior ectopic pregnancies or spontaneous abortions. Those are key histories, key points in the history. And the gestational age is key because in those first 20 weeks, that's where you're more likely going to be seeing ectopic pregnancies and spontaneous abortions occur. Whereas the uterine rupture, placental abruption, placenta previa, vasa previa, those are more likely to be seen later on in pregnancy. So more so like in the second, third, more so the third trimester. So also if it's painful or not is going to be another key finding. So painful bleeding later in gestation may point to placental abruption or uterine rupture, especially if they have a prior uterine rupture or C-sections, which increase the risk. Whereas painless bleeding points more towards placenta previa and vasa previa, with prior C-sections also increasing the risk for placenta previa. So the diagnosis or the prognosis of ectopic pregnancy is related to the severity of symptoms, the time of diagnosis. As ectopic pregnancies are identified early, they're generally treated with methotrexate and pretty well tolerated without significant complications. So should the patient present with a ruptured ectopic pregnancy, as was the case with our patient, the time to surgery is an important factor in determining their prognosis, as if you do not perform that surgery in a timely manner, they may ultimately become hypotensive, develop shock, and it can ultimately lead to death. As I mentioned, 1 in 20 pregnancy-related deaths are due to ectopic pregnancies. So patients who experience an ectopic pregnancy are at an increased risk for subsequent ectopic pregnancy, with a risk of about 15%, which represents more than a 20-fold increase as compared to ectopic rates in the general population. So here you can see an ultrasound showing an ectopic pregnancy. Normally we would see an intrauterine gestational sac, but over here we can see it over by the fallopian tube. And so some take-home points for you guys is that ectopic pregnancies are common. It's something that that I already saw within my first week of being here, and something that we're going to come across. They occur at a rate of about 6.5 per 1,000 pregnancies. And although that number is debated, goes up or down a little bit, but it does account for nearly 1 in 20 pregnancy-related deaths. The diagnosis of ectopic pregnancy is confirmed via transvaginal ultrasound, which shows an extrauterine gestational sac. again, most commonly in the fallopian tube, accounting for 96% of all ectopic pregnancies. Methotrexate is the treatment of choice for hemodynamically stable patients with small ectopic pregnancies, measuring less than 3.5 centimeters without that cardiac activity, without that beta HCG over 5,000. Though surgery is necessary for hemodynamically unstable patients. Risk factors for ectopic pregnancy include increasing maternal age, tubal scarring, cigarette smoking, and prior ectopic pregnancy. So I have my references listed down here, including UpToDate, UWorld, and an article on PubMed. And so a little bit about me. I'm a fourth-year medical student from FIU HWCOM. I'm doing my emergency medicine rotation right now at Baptist in June 2022. And I do want to pursue a career in emergency medicine after I graduate. And I would love to have residency in Florida. So thank you guys very much. And I hope you learned a little something about ectopic pregnancies, as this was a great review for me and something that I was surprised to come across. So thank you. Take care.